to chair this session. My name is Jinshui Xu. I'm a senior health officer of the Taiwan Ministry of Health and Welfare, but I have been stationed in Geneva since 2012. So I work for actually our Taiwan representative office in Geneva. And it's also great to have Dr. Connie here in this room. He will help me to make this smooth session. And we had heard a lot about the innovation at the Congress during past 3 days. And in this session, we will discuss the reshaping healthcare delivery to a borderless system and leading to outcomes which really matter to people. We will learn and be inspired by 5 brief presentations of innovation program, projects, and good practice from various organizations in Spain, in Oman, and in Iran. Actually, it's also in the EMO, the WHO Eastern Mediterranean Region Office. So I will introduce the speaker later, one by one. And as the chair of this session, first I have some housekeeping to announce. First, each of the speakers will be presented one by one, and they will present for a time of 10 minutes. And at the end of the presentation, when all finished, we will have some time for the Q&A session. And for those online, you can ask the question on the app, and when people answer, you can also ask the question from on the Congress app, and also if you prefer to stand up, you can stand up to ask the question. And if you want to know more about the speaker, you can check their biography at the web. Now I will proceed to invite speakers one by one to take the floor. The first speaker is Dr. Antonia Barati, and she is a medical director at the Hospital de Berga, Saluda, Catalonia Center, Spain. And here is a little bit about the speaker. Dr. Balat Maha, I hope I pronounced well, studied medicine in the University of Barcelona, and she is specialized in internal medicine, And she has a PhD in medicine and has a master's degree in healthcare institution management. And she is now the medical doctor in Hospital de Berga. Before that, she ever worked as an internal medicine specialist and also as an emergency doctor. Now, without further ado, Dr. Parada will present his paper entitled Repurposing of the Hospital at Home Unit toward an Integrated Assist Model. Now, Dr. Parada, you have the floor.
Thank you very much. Okay. Good morning. First of all, I would like to thank the members of the Scientific Committee of this Congress for choosing our project and for giving me the opportunity to explain it. It's a big challenge, and I will try to do my best to achieve it. Secondly, I want to explain to you that my presentation will consist in 2 pairs. In the first one, I will present the project, its design, the development, the results, and the original conclusions. In the second, I will talk about the impact that the outbreak of the pandemic had on this project and the changes it has brought. Repurposing hospitalization at home towards an integral model. The spirit of our work is to emphasize the results that have important consequences for people. Over the last 2 decades, the profile of users of the healthcare system, and specifically of hospitalized patients, has shifted, and we found an increase in elderly patients with complete needs. It has had a direct impact of economic and human resource planning, as the needs are much eager. Over the main consequences is that very often, once the acute event has been resolved, these patients usually need a supportive treatment to try to recover as much as possible their functionality. This is called the convalescence period. In our current healthcare model, and in most of the hospitals in our area, patients are transferred to a social and health facility, SHF, to the recovery and the rehabilitation period. These centers have a structural operation similar to acute hospitals, and this model is very expensive and presents some risks inherent to hospital stays, and it also generates a significant increase in health costs. Doing this intervention at the patient's home improves the care and economic results. In 2007, Althea created the Conventional Hospitalization at Home activity, HAH, based on the care at acute processes at home. In 2019, a new model was added, treat patients at home in their convalescence period. This was called Comprehensive Hospital at Home, CHH, focus on the rehabilitative treatments with a multidisciplinary team. There are three profiles. There are three profiles of hospitalized patients that have shown to benefit most from this model of care. Orthogeriatric patients, essentially hip fractures, patients who have suffered a stroke, and patients who have suffered a functional decline after days of hospitalization. To evaluate the effectiveness of the change, an intervention study has been designed with a historical control that compares the care results of the patients who follows the classic process, internally acute plus convalescence in social and health facility, against patients who follow the new model, internally acute plus convalescence at home with CHAH. The intervention group was patients with hip fractures at home, and the control group was patients with hip fractures treated in the hospital. From September 2019 to January 2020, 22 patients were treated at CHAH, 16 of whom were diagnosed with a hip fracture intervention group. They were compared with 36 patients with a hip fracture who underwent convalescence of SHF, control group. You can see statistical analysis found no differences between the two groups in terms of age, sex, and initial Barthel. And we can see in the chart there was a significant statistical difference in the final Barthel scale value, which was much higher in the group treated at home. And there was a big difference in the average of days of admission, much longer in patients treated at the hospital. Conclusions. Although the number of patients is still small, the main contribution of our project is to show that the change from a hospital model to a home model to care for patients with the convalescence period was successful. First, there are benefits in terms of quality of care. For example, better functionality on discharge. In second, there are benefits in terms of economic efficiency. For example, more shorter stays and consequently lower resource consumption. At the same time, CHAH avoids the risk inherent in conventional hospitalization, delirium, falls, medication errors that also generate significant costs for institutions. And finally, it allows for a more normalized transition from the hospital to the community. In the abstract we sent in February 2020, there was a phrase that said, "These are the preliminary study results. The World Hospital Congress will have data updated to 1 year. The project was expected to continue throughout 2020. Unfortunately, the coronavirus altered everything. Now, we are going to talk about the impact that the pandemic had in the project. Altaias Hospital began admitting patients with COVID in the first week of March 2020. In just 14 days, the hospital was completely filled with patients with COVID, many of them critical. All attention was focused on the disease, and only a small part was dedicated to non-COVID pathology. In order to have more free beds, patients without COVID were admitted to the hospital at-home unit. There was an exponential growth in patients cared for in conventional HAH and CHHH because patients preferred to leave the hospital and be cared for at home. At the beginning, only no-COVID patients were admitted at HAH unit. A few days later, no-COVID and COVID patients were admitted for acute processes and for rehabilitative processes. A circuit was designed to treat patients with COVID. The cars were equipped with the necessary personal protective equipment, PPE, and the mechanism for cleaning and disinfecting vehicles and equipment was activated after each day. The results you can see. A total of 271 patients were treated, 106 of them, 40%, with COVID. Of patients with COVID, 96 at HAH with an average stay of 9 days. 10 patients at CHAH COVID with an average stay of 18 days. During the first wave of the pandemic, a total of 2,802 hospital stays were saved, equivalent to occupying 23 beds of 18 weeks. Unfortunately, there are not statistics or studies from this period, but we are convinced that it was safe, efficient, and very beneficial care for patients and for the hospital. The following video is an example of how care was conducted during that period. Finally, the pandemic has also meant organizational change in the home hospitalization unit. I changed the institutions to go and lead a new project as the medical director of Salut Catalunya Central Hospital de Berga. It is a small hospital located near the Pyrenees in a rural setting, but with a close relationship with Altaia because it is its center of reference. It is a very exciting project because Berga's hospital is immersed in a global project of transformation that affects all its processes, both healthcare and organizational. And my desire is to be able to take advantage of this knowledge and experience and implement in Berga in the future the comprehensive home care model as we did in Altaia. Thank you very much. Let me be making a special thanks to all the people who have made it possible for me to be here today, especially Altaia's people, his management, and my current boss in Salut Catalunya Central. Thank you very much.
Thank you. And later we will have a time for QA. And thank you, Dr. Antonia, for introducing such a good example of from hospitalization care to home care. And it's also show benefit in terms of the economic and also quality of care. Without further ado, I want to introduce the second speaker, Dr. Mohamed Al-Ghafri. Dr. Mohamed, he is the Associate Program Director of the Pediatric Specialty at the Alman Medical Specialty Board, and he is responsible for about 85 residents in the program. And he is also a member of the Education Committee and a member of Clinical Competency and the Research Subcommittee. And Dr. Mohamed is the head of the Pediatric Post-Cardiac Surgery Unit at the National Heart Center, the Royal Hospital. And he will present his research on reducing length of stay of 6 cardiac lesions to meet the international standard. Dr. Mohamed, you have the floor.
Good afternoon, everybody, and many thanks for the people who joined this room. Over the next 10 minutes, is it okay? Over the next 10 minutes, I'll be talking about this project. It's about reducing the length of stay of 6 cardiac surgeries to meet the international standards and decrease the length of stay. I am from the National Heart Center, which is under the umbrella of the Royal Hospital in Oman. So this is the outline of my project. Briefly, I'll give you a background about the problem. Then we'll talk about the pre-intervention situation in terms of length of stay. We'll talk in 2 slides about root cause analysis that we did, and then what was our target reduction of the length of stay. Then we'll proceed to the solutions, and then what was the effect of our intervention. And finally, what is our future directions. So just a background about the situation in Oman. So our unit is the only cardiac unit, the only pediatric cardiac unit in the country. It is a 7-bedded unit with 6 step-down units or high dependency units. And the lack of beds is, I think it's international problem when it comes to the intensive care. We noticed that there was no benchmark for transferring patients from the ICU down to the step-down unit and to the ward, and this consequently increased the waiting list. So briefly about the critical care units. We have 3 units. We have the pediatric ICU, we have neonatal ICUs, and we have the cardiac ICUs. So a few years ago, almost all newborns with congenital heart disease will go to the neonatal unit. And some of them will go to the pediatric side. The same is applicable for the medical cardiac patient, like say children with ventricular septal defect who presented with heart failure or chest infection will be admitted to the pediatric ICU. Only open cardiac surgery children will go to the cardiac unit, but this was not anymore the last few years. There was no influx of the newborns to the cardiac unit directly. At the same time, there's also influx from the closed heart surgeries. Many surgeons are not very satisfied to send these babies to the neonatal unit and pediatric ICU. The same also happened for the medical patient who presented with heart failure or chest infection. They will influx to the cardiac unit. And with that consequences, there was increased waiting list. So we started initially and checked what was our median length of stay. So we found that for atrial septal defect closure, it was 2 days. 2 days in the intensive care unit. For the ventricular septal defect is 3 days, and for the tetralogy of Fallot was 5 days. That was at the beginning of our project. Later on, we added 3 another surgery. That is Glenn, it was 3 days, Fontan 4 days, and coarctation of aorta 4 days. So we started doing literature review and to see what is the acceptable length of stay in the intensive care unit. It wasn't very easy to find good figures, as many people are presenting a whole length of stay in intensive care and step-down units. Others present the whole length of stay in the hospital. But anyway, we found some data that are applicable to our project. Then we went to search for the reasons behind the length of stay. So many times there's lack of beds in the step-down units. Sometimes weekends people are lax and not transferring patient out of the intensive care. And sometimes there's no obvious reasons from the progress notes. Also, we find some difficulties in some patients, the preoperative comorbidities. This was more applicable with children with left to right shunt, like ventricular septal defect and AV canal defect. So others, we have severe failure to thrive, some kids with global developmental delay. Others are already on mechanical ventilation before the surgery. Some of them, because of delayed surgery, they have pulmonary hypertension and with chest infection. So this was the root cause analysis that we tried to go for it. We have problems in the environment, which is children with congenital heart disease. We have equipment problem, which is lack of beds. We have also team preference, as some people are a bit hesitant to transfer patient early from the unit. And we have also, there is no obvious benchmark, a system problem. So we set our target initially. So we've set a SMART objective. So for example, ASD closure, we said that we are going to transfer at least 90% of children within 1 day post-surgery. That's by March 2019. The same is applicable for the other lesions, VSD and tetralogy of Fallot. Later on, we added the other 3 lesions that we decide about it. That's Glenn, Fontan, and coarctation of the aorta. I hope that people are aware about these surgeries. If anybody is not aware about these surgeries, I can clarify it. Anyway, so we reviewed our target for 3 times. So as we said, so we started initially ASD 1 day. The performance was great. So push it from 90% to 100%. Or all cases will be transferred within 1 day from the intensive care. For VSD closure, we found some difficulties, as we have many small babies, some of them with chest infection. So we have 2 options, either to push it from 1 day to 2 days, or to decrease it from, say, 75 to 50%. Anyway, we decided to push it to 2 days. For TOF, also, we were able to achieve the target, same for Glenn, Fontan, and coarctation of the aorta. But what we did to achieve these objectives or these targets? So we already talked about the benchmark, and we fix it in we have a daily goal sheet format. So present it on a daily basis, and we already mentioned it down so that everybody is aware about our benchmark and acceptable length of stay. Then we move to something called fast-track extubation. So previously, almost all kids are not extubated in the operating room, and all of them will be sent to the ICU for extubation. With fast-track extubation, so we agreed that certain lesions are to be extubated within 6 hours post-admission. Some of them extubated in the operating rooms, others are in the intensive care unit. Also, we optimize the analgesia and sedation, so we minimize the use of muscle relaxant, and we introduce the Berzidex, so kids are fully awake after the surgery, but at the same time, they have adequate analgesia and sedation. Number 4, when it comes to the in-call system, we have a consultant on-call, not in-house, but we have a senior registrar and sometimes a junior resident with the registrar. So we agreed that all on-call consultant will be among the receiving team for all patients. So all patients will be received by the in-house intensivist. So a clear plan will be set and for the extubation either on the same day or next day. And then we move to train of the step-down nurses. We have many new nurses in the step-down unit who are, you can say, almost ward nurses. They are not familiar to handle kids with chest tubes, central lines, arterial lines, temporary pacemaker, and non-invasive support. So we had great effort in training these nurses in the intensive care as well in the step-down unit. Also, we kept the sister in charge, is the same sister in charge for the ICU and for the step-down unit, so that she can facilitate the flow of patient among the 2 units. So within, say, around 1.5 years, we were able to achieve the target. So we moved, for example, ASD from 2 days down to 1 day. Tetralogy of follow-up, we moved from 5 days to 2 days. So we achieved all the targets for these 6 legions. And surprisingly with that, we started with a waiting list of 260 patients. So we started the project at the beginning of 2019. This data was 2018, but we started the project in 2019. And by March 2021, the list came down to 50. And this drop is despite the ongoing supply of the waiting list, and despite the situation of COVID-19, where our bed situation goes down to from 7 sometimes to even 5 beds. So future direction, we are going to escalate also the length of stay. If we said 75% for many lesions, we can push to 85. Also, we are going to add 3 more surgeries. That's arterial switch surgery, AV canal defect repair, and blood shunt. Also, we'll move to the length of stay to tackle length of stay in the step-down unit as well as in the general ward. So I would like to thank the whole team who participated in this project, including the cardiologists, anesthetists, surgeons, nurses, perfusionists, and respiratory therapists. Without their great efforts, we would not have achieved this target. Thank you very much.
Thank you. We are a little bit late because there were cloning ceremony at 2 p.m. Now we have only 15 minutes left, and we still have 3 speakers. So I think without further ado, I will introduce the next speaker. It's Dr. Cesar Lorenzo Balado. Dr. Lorenzo Balado is a preventive medicine and public health expert, and he has a degree in public health and a master's degree in patient safety and healthcare quality management. And he's also certified as a European expert in quality management in healthcare service. And Dr. Lorenzo Balado will present his research on a new assessment tool to check COVID-19. You have the floor.
Good afternoon. Thank you very much for the introduction. And first of all, I'm going to introduce the hospital I came. Valdebrón University Hospital is the largest hospital here in Catalonia and one of the most in Spain. And I'm going to present our project, Check COVID-19. That is an assessment model for evaluating the COVID management at hospital level with our experience. About the context, first, during the first wave of the pandemics, like in other hospitals in the world, we suffered an excess of demand of COVID patients, reaching more than 2,200 COVID hospital admissions in that period. Like in the rest of the hospitals, in ours we have concern about it, and we have to implement a contingency plan with accelerated changes, activity, organizational, human resources changes that we consider then that it would have effect in a negative way in the quality in healthcare, increasing the risks, increasing the variability in the practice, and of course, in addition, affecting in a negative way on other non-COVID conditions care. In that situation, our board in the hospital asked us to design a new model for evaluate and identify areas for improvement and strengths, learn from the experience of the first wave, and also with two conditions. Frontline healthcare workers must be involved in the project because they had suffered the situation. And of course, we have to adapt our model to establish a model of decision making in an agile way, in short cycles, short terms, by managers. First of all, to achieve this goal, we made an internal diagnostical audit, the hospital, and also bibliographical review of other experience from other institutions in the world. An example of that is here the hospital COVID hotspots report published by the NHS in England in October 2020. I recommend you that report because it's really, really nice. After that, with the participation of different professionals of hospital and the collaboration of the Catalan Organization for Quality, using a Delphi technique, we selected up to 97 evaluation items, grouped into 30 different standards and 6 different areas: strategy, infection prevention and control, works, logistics, organization and human resources, patient care, humanization and education, and finally, evaluation, research and dissemination. Healthcare and non-healthcare areas involved. After that, we validate the model with the participation of other hospital facilities in Catalonia, of the Catalan Health Institute, just to validate and adapt the model to a corporate application. The name is PROSP. It's a mobile application for the use of this kind of checklists and models, and also to validate the methodology of some aspects of the model. This is the structure of the model. It's divided in 3 different levels. The base of the pyramid is the objective to assess the focus of the preparedness and response plans against COVID implemented at the hospital, using a self-assessment questionnaire. Second level, carrying out internal on-site walk-rounds to assess the compliance and implementation of the different procedures implemented at the hospital. And finally, the dashboard of indicators and 2 different types of surveys, one for professionals, one for patients. Well, the first level, self-assessment questionnaire, is aimed to managers' evaluation, evaluated by the responsible of the main areas involved in the plan, using a scale of 5 categories, rated from 0 to 4. And some of the items included in the model are considered core or mandatory because in the validation process, it was evaluated as items with the application is mandatory for all kind of hospitals, regardless of their level of complexity. And finally, the system, all the assessments must be justified using the appropriate documentary evidence. The second level, on-site backgrounds, we have carried out up to 28 audits at the hospital in 6 different areas: emergency departments, hospitalization, surgical areas, ICUs, outpatient common areas. Internal auditors use the corporate application using the mobile for completion, and also that application allows to upload the documentary evidences and also to add comments about areas for improvement, suggestions, or strengths identified at the audit. Finally, in the evaluation module, based on a dashboard of indicators for evaluating the impact and the compliance of the plan, and 2 different types of surveys, one for patients, a post-discharge patient survey, for assessing the experience of patients admitted to the hospital throughout the different waves we have suffered, five waves till now, and I hope no more. And finally, professional survey to evaluate the degree of knowledge and compliance by the professionals of the different protocols and procedures implemented at the hospital. That's the schedule of the implementation of the project. First year, 2020, we have designed, piloted, and implemented an improvement plan of the first version of the model. And after the new evidences and experiences all along the 2020, at the beginning of this year, we have designed and validated a second edition of the model. After that, we have implemented it, and we have started an improvement plan that is currently in progress. Here you are the results slide. We have obtained different results in the different levels I have taught before: self-managed assessment questionnaire, evaluation, and on-site walkarounds with different results depending on the area evaluated. But more important than the results, the scores, are the 96 good practices identified and the 42 areas of improvement. And just to conclude, in a post-pandemic context, like now or in the future, we consider from the experience that the application of this model would be useful for us for future contingency situations, for future crises, pandemic crisis or not pandemic crisis, as a stress test model, very similar to the stress test models of the banks, but applied to a healthcare system. About the check COVID validation, we have validated this model for its multi-center application, the Catalan Health Institute, and we think that this model can be implemented in different hospital facilities regardless of their level of complexity. And last but not least, we think the methodology is applicable to other areas different than hospitals, like, for example, residential aged care facilities or primary care that is 2 levels or 2 healthcare areas that have suffered in front line the pandemics and we think that these levels are very important to fight against this crisis and others. So it's the last slide. Here you are, my contact data, and thank you very much for your attention, and I will wait for your questions. Thank you very much.
Thank you, Dr. Torrento Prado, for your excellent presentation introducing this new assessment tool. Now, I will introduce the next speaker, Dr. Tony. Dr. Tony is a family doctor at the Iba Balakara Slab area in the Barcelona, and he's a family doctor and responsible for corporate and social responsibility. And he's also an associate professor of clinical management at the University de Vic, University Central de Catalonia, and the professor of master degree in health management at OBS Business School. Dr. Tony will present his study, Do Patients Have a Clinical Eye? Dr. Tony, please.
Okay. Sorry. First of all, I want to thank to the scientific committee of this Congress that allowed present you our work that is from primary care in a Congress of Hospitals. Also, thank to my partners on this work that you have in this slide. Our work is try to compare primary health centers according to user satisfaction. In Catalonia, we have 372 primary health centers. 288 are managed by the Catalan Health Institute, public direct management that represents this percentage. 13 are associate-based entities, and 71 belong to integrated health organizations. In Catalonia, we have these tools. The survey of Plaenza that measures the satisfaction of all the primary health care. And for the other side, on the right, we have the report of the Result Center from ACUAS, that is the Agency of Evaluation and Quality of Ministry of Catalonia from Health. Our work is a retrospective observational study. We choose the 13 with the lowest satisfaction primary health care centers, and the 13 with the highest satisfaction. The aim of our work is to compare and to describe the characteristic of the teams with the lowest satisfaction and the 13 with the highest satisfaction. Respect to the methodology, the Catalonia User Satisfaction Survey, Plaenza from the year 2018, and the indicators of the primary health center of this year of the Catalan Agency for Health Quality and Assessment, AQUAS, of the Ministry of Health of the Generalitat. This is what we used. The variables of the study used are, for example, in the group of general, we have, for example, the size of the primary health care center, the number of visits, for example. Also, we use variables of adequacy, for example, avoidable hospitalization, pharmaceutical prescription quality index, variables of effectiveness, for example, the flu vaccine coverage, efficiency, for example, the public pharmaceutical expenditure, quality and user satisfaction, in a number of 36. We use comparison of average between the two groups. The main results was the 18% of the primary health care centers evaluated with the highest user satisfactions belong to X, 10% are EVAs, and 10% are OSIs. There were no significant difference between the two groups, or the highest satisfaction and the lowest satisfactions, regarding socioeconomic index, triple viral vaccine coverage, avoidable hospitalization rate for chronic obstructive pulmonary disease and heart failure, neither according to the volume of referrals made, nor the control of blood pressure, nor the comprehensive assessment of people in home care. The most satisfied primary health care center with their uses are significant smaller, higher number of visits per assigned person, more expensive the hiring per assigned user. They have better pharmaceutical quality index, lower cost per pharmacy user, and fewer polymedicated patients. They also have better control of diabetes and increased coverage for influenza vaccination. The average and median duration of work disability is longer. Primary health care centers with less customer satisfaction have more users assigned, less visitors, cheaper hiring, and fewer days of transient work disability. Then we can go to the conclusions. So, primary health care centers with the highest satisfaction of their user are smaller and they have higher frequency. They are more expensive to hire, but they have better clinical control, better prescription quality, fewer prescription, and lower pharmacy cost, and fewer also polymedicated patients. Therefore, we confirm that patients have a clinical eye. I don't know if clinical eye is a false friend in English, but I think that means that patients are able to distinguish quality. We don't know why, but they do. Organizations and the health systems, we think that as a whole should not only consider patient satisfaction, but also monitor and implement changes based on patients' opinion and contribute to make Berwick's triple aim a reality. Let me say you now some other conclusions that are not in the presentation that maybe it will be another work. The main conclusions, it will be that the main stakeholders of health organizations are the citizen, the patients, obviously. We think that with our work, we show that the opinion of patients must be taken into account, then their satisfaction experience, that we call PREM, is associated with teams with better care results. AQUAS must make progress in the incorporation of PROM indicators. The COVID pandemic is forcing primary health care to reinvent and reorganize itself. Aspects such improving value practices, the incorporation of information and communication technologies, defining the face-to-face visits and the telematic visiting, and along, etc. Our organizations are clear that we need to incorporate the voice of patients, but we still don't know enough about it. This work reinforces us in this conviction. I hope that in the next Hospital Congress, I can tell you how we have progress in this work. Thank you very much. And here you have my data.
Thank you, Dr. Tony. I think we will listen to your presentation in the next Congress in Dubai. Now, without further ado, I will introduce our last but not least speaker, Dr. Hami Habachi. Dr. Hami is the current the regional advisor for the hospital care and management in the WHO Emerald region in Cairo, Egypt. He is also an academic member at Iran University of Medical Science. And Dr. Hami has a PhD in health policy and management from the University of York, UK. And he's an associate professor of health policy and management at the Iran University of Medical Science. And he works also as an international consultant in the area of hospital management in different countries. And before that, he also served as a hospital director, policymaker, and advisor for more than 20 years. And he teaches in master's and PhD program and published a lot of articles. And Dr. Hami will present his research on the patient safety culture assessment in the Emerald region. Dr. Hami, please.
Hello, good afternoon. I know the time is very limited. I try to make my presentation 5 minutes. Very quick, very quick. I hope so. Many thanks for this opportunity. This is the piece of research that we started 2015 before I joined the WHO, and we updated the research in 17 and 20. Can I have the slide clicker? Oh, yes. Safety is the heart of the health service delivery, and the main issue is first, do not harm. We know that, and it is the important part of the quality improvement. But in low and middle income countries, it is an issue that we need to focus more. There are some facts. Unfortunately, 1 in each 10 patients in all over the world, they suffer from the safety issues in the inpatient sector, and over 3 million deaths per year is related to the safety issue. And in low and middle income country, unfortunately, 4 in 100 people they die because of the unsafe care, and $64 million per year is related to the unsafe care, is equal to HIV. You know that we haven't that much programs for HIV, but these are the some unfortunate and facts. But fortunately, 70 to 80% are preventable. We can prevent those medical errors. If we want to improve the patient safety, we need to build the patient safety culture. And the culture, what do we mean the culture? All the behavior, beliefs, values, and underlying assumptions that they direct us in order to not to harm to the patients are making our patient safety culture. And I'm happy the colleagues from Oman are here. They have done a lot on this in the region that I can elaborate on this. But really, the way we think, the way we behave, the way that we believe are things that it shows the safety. Our colleague from Spain, he mentioned the PHC, one of the, or even the other colleague from Barcelona, they mentioned one of the issues that they were measuring was safety and quality issues. But we need to assess the safety culture. If we want to assess the safety culture and if we want to start improvement programs, we should have tools. Several tools are available, mostly for hospitals. They measure the perceptions of the day-to-day practices and measure the beliefs and values. One of the tools has been used very extensively in the literature is Hospital Survey on Patient Safety Culture, HSOPS. It's done with AHRQ, it's the US Agency for Quality Improvement, it's very renowned. And it is consisting 12 safety culture dimensions and including 42 items, 42 questions. Fortunately, in our region, when WHO introduced the Patient Safety Friendly Hospital Initiative, it was more focused on patient safety culture and patient safety culture assessment. And it has been started 2007. These are the dimensions of the HSOPS, Hospital Safety Culture Assessment Tool. You can just have a look. I don't want to read them. It is emphasizing on teamwork, staffing, behavior, reporting, incidents reporting, communication. These are things that we measure in the hospital. Since 2017, this initiative has been started. We wanted to do a systematic review to see how safety culture has been improved and has been measured. So we developed the proposal and for this systematic review to understand the overall patient safety culture assessment in the region. Very quick, we did a comprehensive search strategy, updated 17 and 20. The empirical studies in hospital using HSOPS in English and in the region. And we did the very systematic approach for the data analysis and data management. We identified 24 studies. And those 24 studies, 18 out of 24 are after 2012. So it is just 8 years. You see, it is very, very young. And countries, just in the region, we have 22 countries. And from the very rich countries to very poor countries. And 40% of the countries only assess the patient safety culture. And about half of those studies are coming from Iran and Saudi Arabia. And then Oman, that they have done a lot on patient safety improvement. Aim of the study was measuring the patient safety culture or validating the questionnaire. Method was a cross-sectional survey. And those 24 studies included 22,000 staff, human workforce, and mostly in the hospital sector. I just quit this. This shows how is patient safety culture in the region. The highest score that we saw in these studies was teamwork within hospital units. Teamwork within hospital is much more stronger than teamwork across the hospital. And lowest score shows why our region has problems with the patient safety. The least score were hospital manager support for patient safety. It seems hospital managers do not support enough patient safety. There is a punitive culture. Still, we punish the people for the errors. We say who. The hospital transfer and transition and handover is another area that is not supported. Staffing for patient safety is another, and teamwork across the hospital units. Generally, you see the role of leadership should be improved, and the staffing for this and team working across the hospital sector. So conclusion, in our region, we need more attention to the patient safety. and measurement of the patient safety culture, and it is a regular assessment and improvement. Role of clinical and managerial leadership is very important. HSOPS is a vigor and valid tool. We see in the even low resource setting it works, and regular assessment of patient safety culture should work. I would like to re-emphasize the work that Oman has done. Patient safety culture friendly hospital initiative is a WHO initiative that gives the hospital 4 grades of patient safety, and Oman is one of the countries. They have 13 hospitals. They have taken grade 3 and grade 4, and we are proud of their work that they are doing there. Conclusion is WHO is supporting the patient safety improvement, patient safety culture assessment, and thanks for giving this opportunity. I try to be as much as fast possible. Many thanks for your attention.
Hello, thank you all speakers. I just got a note from Cardi. The note said we need to finish this session 1:50. So that means we only have 7 minutes for QA, and then people need to move to the auditorium for the closing ceremony. So in this case, I think I will still invite all the speakers here. And we have 7 minutes, so we need to raise questions and answer them very quickly. Yeah, let me check. Is there any question in the app?
And can we ask as well?
Yeah, sure. Sure. So no question on the app. So is there any question from the audience here? No, oh, you want? Okay, please.
Question from Professor regarding the assessment that you did. Just one thing is, because most of the participants of the study were Spanish. Did you do anything for the migrants or the people, not Spanish people in your study, to see how is the difference between satisfaction of Spanish and non-Spanish, or mostly very Spanish?
In our
Study, assessment.
In our study, Taxamut, that is the agency that allows the healthcare assistant, not distinguish all our citizens from Catalonia, not distinguish
the migrants or not migrants.
No.
Oh.
We don't, our intuition, inspiration.
It's the same. No, I know, but
not
just I
different.
wanted to see if there is a subgroup analysis. Oh, thank you.
Okay. So I do have some questions for the speakers. My first question will go to Dr. Andoni. Yeah, you just present the case for the hospitalization at home. So that's a very good model. And I have a question about how the patient they pay their money. Who pay the cost, because that is very important. If the home care quality is good, and then if the money is already the patient can also save the money, I think that will be also provide some incentive for patient to stay home and receive the same quality of care.
Who pay the service? The public health system. For the government is cheaper to pay the system of convalescence at home that convalescence in SHF, because it's more efficient and it allows to be bed free, and the results are more good in their capability of this or the previous state. It's more efficient system, and governments understand that it's more is better to invest in hospital home and CHAH and comprehensive model that in SHF models.
Mm-hmm.
Now the presentation for this speaker, no? You are presented some numbers that the complications with the hospital are very important, and they generate very high costs for the system. No? That if you bring this attention at home, it's more efficient, and you can avoid this complication. And the public system pay for that.
Okay.
It is very important that to try well the patients. You can distinguish the patients that can benefit from them, or the patient that don't need. That is the most important work, is to try what the patient can benefit that or cannot benefit that.
Yeah, Connie, please.
So this is a wonderful range of presentations. Some of your projects started before COVID, some because of COVID, some COVID didn't seem to matter. So my question is, given the pandemic, did COVID impede your project, facilitate your project, or not make any difference? So what do we as administrators learn from COVID? Can all this go on anyway? And what does the pandemic or disruption, what does it mean? Any or all of you could comment from your perspective.
Yes, who wants to start?
Okay, I can start.
Moment.
So I think for us, the COVID, we did not affect as much as cardiac intensive care. Why? Because we stand firmly. We said we cannot decrease the number of beds more than, say, 1 or 2. Because consequently, these patients, they will come to the emergency room. They're going to create other problems for us. So we stand firmly with the administrators, and we say at least from 7 beds, we go down to maximum 5 beds. And we cannot go down further. Our team also participated. Some of our doctors also and nurses were taken to the COVID area. But I think, personally for us, COVID did not affect us much.
Dr. Oh. Dr.
I try to say in my explanation, I feel that managers always speak about patients or citizens, but they are afraid of integrated in the organization and work with. I know it's hard, it's difficult, but it's necessary. And our work is try to make an impulse of this movement to integrate patients in our healthcare organizations and work with patients and try to make co-creation of services, and because patients are good judges of the services, and they can improve our organization with their thinking.
Very quick. Regarding patient safety, really COVID affected. Specifically, quality improvement programs have been affected. For example, many of the accreditation surveys were stopped because the people were very busy. Although we were focusing and supporting countries to go for IPC, infection prevention controls regarding outbreaks, but generally quality improvement programs, because shifting on deployment of the staff, and also the hospital managers, they're not ready for that much, work. Really, they needed training for the preparedness, response, agility. So I think, specifically to my presentation, I think safety improvement and safety initiatives have been affected. And also another thing that has been affected, and I think we need to consider, is essential health services. It has affected the essential health services that we are providing for chronic diseases because of the lockdown, because of the closing the centers. And when the centers are closed or patient doesn't come, the quality of care that we are providing for them cannot be measured, cannot be assessed, cannot be followed. So generally, COVID-19, to my opinion, it affected the continuity of care, safety of care, and all. But it was an opportunity that managers learned how they should be more agile and more adaptable, rather than to be reactive.
Can I add something about COVID? So I talk about the cardiac side, but the general side, the pediatric side, we used to have 8 beds. They used to be full before the COVID. But with COVID, the number of patients dropped down to 2, 3, 4, 2. At some stage, one doctor took a picture beside the screen, 1 patient. And surprisingly, when the COVID is coming down, the other virus is taken over. And now we moved from 8 to 12 beds, 50% increment. Other viruses are taking over. And now we cannot go down below 11, 12, 11, 12, 11. From 8 down to 2, and now to 12.
In our case, for sure, it has facilitated the project. But more than this, the COVID situation, we think have been an opportunity to change the model, no? To reshape is the title of this room now, and it's an opportunity to strengthen the assessment way, to improve the system, and also to adaptate our system to an uncertainty context. The context is very complex, and we have to adapt our system to a very complex context.
Thank you.
I'm agree.
Okay.
For the future. Yes.
Okay. Because time strain, I need to close this session, and I will suggest the audience online and on-site, you can also email the question to the speakers so they can answer your question. So now I thank you all speakers, and thank you. Yeah. Now the session is closed.